Hello everyone, this narrative review is going to be about right lateral mini thoracotomy versus median sternotomy in mitral valve repair. The items of this review are going to be our abstract, introduction, methods, results, future directions and limitations, and finally our references. Let's talk a little bit about mitral valve affection. Mitral valve affection is a broad term that includes both stenosis and regurgitation of the valve. Current treatment of this disease is mainly surgical. The surgical techniques have been improved and enhanced over time, starting with median sternotomy, which was the first surgical technique, which included performing an incision in the midline of the thorax right over the sternum, to a current minimally invasive technique of right lateral mini thoracotomy. The technique of right lateral mini thoracotomy involves a combination of thoracoscopy and normal visualization. This technique is called Carpentier. This narrative review consists of cohort studies and one meta-analysis and systematic review. This narrative review discusses or focuses mainly on postoperative outcomes and complications when comparing the two techniques, which are MIVS and median sternotomy. To introduce our first cohort study included in this narrative review, the patients performed mitral valve repair for the first time, so these patients did not perform any uh, operations concerning the mitral valve prior to this one. Etiology of mitral valve affection ranged from degenerative diseases to rheumatic or even infection. Mean age of these patients were or was 59.3 years old. The surgical technique performed, like included in this narrative review, is anterior or posterior lateral thoracotomy. Cannulation was either central or peripheral. Cannulation is cannulating the artery. Central cannulation is cannulating the aorta, and peripheral cannulation is cannulating the femoral vein. Postoperative outcomes and complications were compared with median sternotomy, and that is the main um, focus of this review. Mortality rate in this study was 2.0%, mostly occurring from degenerative mitral valve affection and old age. Introducing the second cohort study. The study was performed on patients who have previously performed median sternotomy. Now, this median sternotomy performed prior to the surgery had many reasons, ranging from aortic valve affection to mitral valve affection and even CABG. Results and complications again are compared to median sternotomy. The meta-analysis and systematic review was performed on 45 studies until the year of 2013. All the patients performed lateral thoracotomy, and again outcomes and complications were compared. 20,000 patients were included in the study. The method of the first cohort study, operative techniques performed were either anterior, like we said, anterior mini thoracotomy, which obviously was performed in the bulk of patients, and posterior mini thoracotomy in only 1.4%. The type of cannulation, like we discussed, was either central or peripheral. Central cannulation is two types: retrograde percussion or endo-aortic balloon occlusion. There were certain definitions that had to be put um, to make the inclusion criteria of the study, as well as carefully and precisely compare results with median sternotomy, obviously. Mortality that was defined as the death within 30 days from the operation, and stroke was newly arising lesion on cerebral imaging, meaning the patient did not have any lesions prior to the surgery. The lesion was either transient or permanent. This is a table showing you the risk factors of death, which we said increased age, obviously, mitral valve insufficiency, COPD, peripheral vascular diseases, and atherosclerotic aorta. Obviously, peripheral vascular diseases and atherosclerotic aorta helped in embolus and stroke formation, which also caused death. Risk factors of neurologic events, again, we see the same thing, increased age, emergency procedures, so on and so forth. Risk factors for neurologic event, bootstrapped, again, retrograde perfusion. Retrograde perfusion also helps in stroke or uh, provokes stroke formation, obviously, by embolus formation. The methods of the second cohort study, all the patients underwent right lateral mini thoracotomy with Carpentier technique. Antegrade perfusion was the choice instead of retrograde perfusion, again because antegrade perfusion was shown to have decreased risk of embolus formation, therefore decreased risk of stroke formation. Preferred site of cannulation is the ascending aorta. Endoaortic balloon clamping, performed in cases of ascending aorta, cannot be safely clamped for delivering crystalloid cardioplasia. Like we discussed, Carpentier technique is a combination of a normal visualization and thoracoscopy. This is a picture showing the incision performed for the minimally invasive technique of MIVS. A 5 to 7 incision on the anterior anterolateral right surface and the fourth or fifth intercostal space. The incision is widened by self-retaining retractors. This is another picture showing the performance of the surgery. We have two trokers and a camera. One of the trokers is used for ventricular vent and CO2 insufflator. In the systematic review and meta-analysis, there were inclusion and exclusion criteria. Inclusion criteria was randomized or non-randomized trials, CS or conventional sternotomy, MIVS, whether performed by humans completely or robot assisted, and mitral replacement and repair. The exclusion criteria was mitral disease redo surgery. Continuation of methods. The results of all complications in the study had the same endpoint, a mortality rate of 30 days and a stroke. We compared also presence of AF and aortic dissection, blood transfusion and blood drainage volume in comparing both the surgeries, cross-clamp time and CPB, which is cardiopulmonary bypass. To continue the comparisons, surgery duration, ICU stay duration, and respirator dependence duration. The results of the first cohort studies showed mortality rate of 2%, like we said, mainly due to old age and degenerative etiology. The risk factors of these patients were mainly COPD, peripheral vascular disease, and atherosclerosis. Risk factor for neurologic affection, like we said, mainly retrograde cannulation, which provoked or was found to be associated with higher stroke rates. Patients who underwent peripheral cannulation were under high stroke rates due to embolus formation. Now, obviously, before going for retrograde cannulation, CT angio and transesophageal echo should be done to make sure that the aorta is affected or has abnormalities. The second cohort study, which is post-operative morbidities, again it shows stroke, whether transient or permanent, 30-day mortality rate, pulmonary complications, AKI, bleeding, AV block, and post-operative AF. In the systematic review, 3 studies again were randomized trials and the rest were cohort. 19 studies performed endo-aortic occlusion while 16 performed cross-clamping. Again, you will see that the mortality causes are indifferent or insignificant between CS and MIVS. Stroke rates, as shown here, um, there is not much of a difference, except of course if the patient undergoes um, peripheral cannulation. This increases stroke rates in MIVS. Other outcomes such as blood transfusion, amount of blood loss, ICU time, respirator dependence, and stay in the hospital was all decreased in MIVS, which helps in decreasing the costs for the patient and the healthcare services. Cross clamp time and CPB time were longer in MIVS, obviously, since we are clamping the arteries. There was no difference in aortic dissection between CS and MIVS. Operative data: 55 patients underwent aortic cannulation, while 118 underwent femoral. 58 patients underwent cross-clamping, while 72 underwent endoaortic ballooning. Mortality rate within 30 days here was a little bit higher. Now, if you look at causes of death, again, neurological complications, multiple organ failure, low cardiac output, and sepsis. The complications are either stroke, AKI, which is acute kidney injury, reoperation due to failure, and pulmonary affection. On discharge, patients underwent echo to make sure that there was no minimal or no mitral regurg. Only one patient showed moderate regurgitation. Follow-up was completed in 100% of patients, and in follow-up, 7 patients were found to have moderate mitral regurg after undergoing echo, 17 late death cases, 5 of which were cardiac related. To wrap up things in our conclusion, right lateral mini thoracotomy is now surgery of choice, obviously due to all the decreased timings that you see here in IC time, respirator dependence, blood transfusion, stay in the hospital, and minimally invasive, a very minimally invasive technique. It all uh, compiles to be very, the patients are very satisfied with their outcomes, and so are the doctors. Central cannulation is of choice, like we said, due to decreased stroke rate. Preoperative complications are more or less the same, and in between, obviously, the CS and MIVS. Enhancement of MIVS technique uh, perfected, which has been perfected by doctors over time, has led to decreased complications and enhanced outcomes. Limitations and future directions. What would we like to do in the future to establish an even more solid background or solid ground is to measure the results of MIVS versus currently performed sternotomy, because in all of the studies included in this narrative review, the sternotomy was done in very old studies. It is not done anymore nowadays. Finally, I'd like to thank Dr. Amr Abdelbath and the MIRS community for their assistance and comments that improved this narrative review. These are my references, and I'd like to thank you for joining me. I hope the review was of assistance or added to your information. Thank you.